Good afternoon, good morning, everyone. Welcome to Sunstar webinar series entitled Let's Talk Oral Health. My name is Rachel and I will be your host today for this third episode of the year. First, I would like to talk about the logistic points. If you are joining us through the registration platform Eventbrite, you may want to switch to YouTube by following the link at the bottom of the screen in order to enjoy the full screen mode, but also to use the chat box to ask your questions to which we will answer, or our experts will answer at the end of the session. So we already had two webinars on this webinar series about Let's Talk About Health. It was focused on the home-based oral care, within dental specialties. The first episode was on periodontology, and the second one was on orthodontics. The challenges, the special demands, and the strategies they came up with to cope with those. Today, we will have a special medical discipline, which is cancerology. Specifically, what can the oral health professionals do in order to support the cancer patient and alleviate his or her burden when it comes to home-based oral care? And we will see that these actions can actually even support the compliance to the overall cancer treatment itself. To do so, we have invited three speakers to talk about the topic and to give you an overview from different perspectives. However, because of a last-minute schedule conflict, Professor Giovanni Scambia will not be able to join us since he's still in surgery. So his part will be covered by Professor Carlo Lajolo, that I'm happy to introduce to you right now. Hello, Carlo.
Hello, everybody. Hello, Rachel. Thank you very much for inviting me, and thank also Sunstar team for this beautiful project.
Thank you for being with us and to bring your expertise and to help us cover the part of Dr. Scambia, who, of course, we understand, being still in surgery, has other priorities, obviously. So please let me introduce you to our audience. So you are actually an associate professor in the Head and Neck Department in the Gemelli Foundation, Polyclinic University within the Catholic University of the Sacred Heart in Rome, Italy.
Yeah, in Roma, yes.
Yes,
No, go on.
And Dr. Scambia is actually also part of the same foundation. That's why you work closely together, and you will, of course, obviously, you are a specialist in cancer treatments as well.
Yeah, so, he is the dean of the IRCS Fondazione Policlinico Gemelli. So he's an oncologist, a gynecologic oncologist. So unfortunately now he's in a major surgery, so he cannot be with us today. But we co-work very much in many different protocols.
Yes, we're sure it will be well covered by yourself, no problem. But to cover the rest of the discussion, you will be joined in the conversation by the second speaker of today. And I'm happy to introduce Miss Susan Cotten. Hello, Susan.
Hi, Rachel. Hi, Carlo. Thank you so much for having me. Thank you, everyone, for joining us. And Sunstar, yes, for this important conversation we're going to have today.
We thank you for being with us, for also bringing your expertise from a different perspective, as you are a dental hygienist and you are specialized actually in oral cancer screening. You're based in Colorado, USA, whereas Carlo is in Italy. So we will have different perspectives also from both sides.
Yes.
So with this line of speakers, let's us waste no time and dive right into the topic. Today, Maybe by starting with a bit of context around cancer therapies, since obviously this topic could be covered in 1, 2, or several webinars only about that. However, a short introduction for our audience about chemo, radio, and other cancer therapies and their consequences on the body, specifically on the oral cavity, will be important to frame the discussion. So, Carlo, may I ask you please to open the conversation and tell us what is the link between oral health and cancer therapy?
Of course. Thank you, Rachel. Yes, Rachel asked us to treat a very wide topic because the correlation between the oral health and the cancers and the support we can give this patient is very wide. And so we decided to discuss just part of the many different topics that links the oral cavity with the other part of the body, of course. And if we can have the first slide, Rachel,
yes.
Can you? Yes. So, of course, among all the cancer patients, there are a huge group that suffer from head and neck cancers. This type of cancers are very frustrating for patients and for therapists too, because affect a part of the body which is highly developed and which is used for many different functions. We speak, we breathe, we taste, we of course swallow, and so there are many functions that pass through this part of the body. And so among all the patients who have cancer, this subset of patients are particularly demanding for the pathology, for the surgeons that perform surgery, of course, but also for other doctors who take care of this district, of course. And mainly, within this subset, there is another little subset that of patients who are affected by oral cancer. Oral cancer is mainly squamous cell carcinomas, of course, and it can be treated mainly with the measure oncologic surgery, which is performed generally by ENT or maxillofacial surgeons. But dentists can play a very important role, as we will see, even in the early diagnosis, but also in the support of the therapy that these patients undergo, because this patient can undergo also radiotherapy of the head and neck district, which is, of course, it doesn't cut the skin or the bone, but it can impair the function of all this district. And finally, this patient can undergo a combination between radiotherapy and chemotherapy, which worsen the side effects of the radiotherapy, as we will see. Of course, patients who suffer from tumors of other regions can undergo chemotherapy, for instance, and so they can have oral mucositis. So we can help also those patients. Can we have the next slide? Of course, as we can see in this panorex, our patient undergo measure of oncologic surgery with the extirpation of the tumor of the mouth, of the oral cavity, which impairs a lot the quality of life of these patients. We have to say, first of all, that worldwide there are almost 300,000 of new cases of oral cancer. So it's not, and we have to consider that in some geographical areas, this percentage is much higher. For instance, in southeast of the world, India, China, where some habits contribute to the development of this cancer. As we can see from this panorex, of course, this patient receive a major surgery. You can see the fixation screws of the jaw, but we can immediately understand that the quality of the oral health of this patient is very poor, very impaired, not only from the surgery, but also because one of the risk factors of this cancer is, for instance, a poor hygiene, is smoking habits, is drinking habits. So all risk factors that affect also the quality of the mouth and the health of the teeth, of course. If we can go to the next slide, which is the same patient, but the clinical view of the same patient, we can easily understand that this patient, of course, has a poor hygiene, and probably he had before the onset of the cancer. But of course, the major ENT surgery and maybe the radiotherapy that he has to undergo can make his situation even worse. So it's crucial at early diagnosis of oral cancer, because at the moment, surgery, major surgery and radiotherapy are the only therapy that, the main, not the only, but I can say the main therapy that the patient can undergo. So are quite demanding also for the patient. Susan, what do you think about how can we manage, how can we do an early diagnosis of oral cancer? I think that is a crucial point.
It is, Carlo. Yeah, thank you for asking. And as you so eloquently said, you know, head and neck cancers affect all of these important structures for our speech, our communication. It's how we sustain life through eating and drinking. And so early detection, of course, of any cancer is key in the results and the long-term longevity of someone's life. So early detection of oral pharyngeal, or any head and neck cancers for the dentists and hygienists, really our gold standard has been that visual and tactile, extraoral, intraoral evaluation, thoroughly palpating the lymph nodes of the head and neck, palpating the glands of the head and neck, assessing the musculature, you know, for any asymmetries, abnormalities, assessing the thyroid for asymmetries, and especially the swallow, because we know now through evidence and research that any deviation in swallow or difficulty swallowing could be a sign that needs further investigation. So that's, you know, a quick overview of the extraoral. Intraorally, making sure that we're thoroughly assessing that oral pharynx, the soft palate, the uvula, the palatine tonsils, and that posterior third base of the tongue, especially those areas, because that's where HPV presents. And that's, we know now, epidemic in numbers, HPV oropharyngeal cancers. And then thoroughly assessing the anterior portion of the mouth, palpating the floor of the mouth, assessing the palate, the buccal mucosa, assessing all of that, the anterior portion of the tongue. And are they able to, you know, move their tongue side to side? Is there any disruption in tongue movement? And then we also know now, based on evidence and research, that it's not just what we see and palpate, but signs and symptoms that we should be asking the patient about. Again, difficulty swallowing, sensation of something caught in the throat and it won't go down, indication that there's maybe a tumor, something going on back there. Any persistent sore throat, cough, hoarseness, change in voice, ear or jaw pain. And when we say persistent, they usually say anything that persists for 2 to 3 weeks. So for us as dentists and hygienists to really be thorough and consistent in doing that intraoral, extraoral, and asking the patient about those signs and symptoms, I think are key to early detection.
I completely agree with you, Susan. I always say this to our students that they have to inspect all the part of the oral cavity. There are some parts that are difficult to check. You have to go and check them.
Yes.
Otherwise, you don't see them. The floor of the mouth, of course, the posterior tongue, of course. And you, as you said, you have to touch it. You have to do a physical examination of all that parts. I completely agree with you in this sense. And I have to stress that the prognosis of oral cancer, the best prognostic factor for oral cancer nowadays is the stage at the diagnosis. So as soon as we get an early stage, the prognosis of the patient is much better and is probably at the moment the most important prognostic factor. So it's important that we play a fundamental role in the diagnosis. And I have to say that Sunstar helped us in performing that, because there is also a booklet that we can download from the website. So maybe we can have the next slide. Of course, as I told you before, of course, our patients undergo mainly ENT surgery, major ENT surgery or maxillofacial surgery, but some of them and many of the other patients who have head and neck cancer undergo radiotherapy, which of course is a really heavy therapy. Even if the new technologies allow us to spare some organs, like salivary glands, for instance, as we can see in these dosimetric curves, of course, these, for instance, salivary glands are anyway impaired, maybe less than one time, but they are still impaired. And so we have many side effects, as we can see in the next slides.
Yes,
especially
indeed.
maybe we sorry oh okay, in this slide we can see the list of the side effects. Of course, we divide them between acute and long-term or chronic side effects. Of course, some of them are really severe, really life-threatening, like mucositis, especially in grade 3 and 4, as we will see later on in the webinar. Some other are more less severe, but still frustrating the life of our patient, like hyposalivation, for instance, and xerostomia that this patient develop quite frequently. And moreover, we have some very severe side effects like osteoradionecrosis. Of course, we cannot treat all these side effects in this webinar. Maybe we can focus on some of them. So I think, and we decided with Susan to treat mainly mucositis, infections, and dental caries and hyposalivation. We are linked together because here the dentist can help very much the life of the patients. So probably we can go. Susan, do you want to add something, Susan, to this slide?
You know, Carlo, I think you've covered it pretty well. So thank you.
Maybe we can go to the next one, Rachel.
Yeah, to the next one, to answer the questions of, the main oral conditions and the associated care that you can suggest and recommend to our audience, specifically, as you mentioned, on two main conditions, being oral mucositis first. So let's move indeed to this condition for you to explain, knowing that, of course, it will be one of the main oral conditions that you will treat.
Yeah, Rachel, thank you for this question, which is quite demanding and quite important. We in the late 80s, Sonis, which we can see his paper here, described first the hypothesis of the mucositis pathogenesis, and he went further on and published in 2007 this paper where he described the pathogenesis of the mucositis. Mucositis can happen during either radiotherapy or chemotherapy, and it can affect the mouth, but it can affect all the digestive tract. Of course, we are more interested in the oral cavity. And if we go further with the slide that have an animation, the pathogenesis hypothesis is that the injury affect both the epithelium and the connective underlying tissue. And this damage produce a cascade of mediators, especially TNF-alpha, interferon gamma, so many different inflammatory mediators, which plays a key role in the death of the epithelium and in the inflammation that happens in the connective underlying tissue, up to the formation of an ulcer. Okay, so the inflammation is so high, so hard, strikes so high the epithelium and the connective tissue that it dies at the end. And so it happens an ulcer, and this ulcer slowly can be recovered by the organism through the epithelium, the growth of the epithelium, the growth of the vessels in the connective tissue, and usually it recovers without a scar. But of course, this is the pathogenic mechanism. But as we can see in the next slide, we can grade the mucositis according to WHO classification in 4 stages. This is very important for us because we follow the patient who undergo, for instance, radiotherapy of the head and neck region, and we see them before the start of the radiotherapy. We follow them 2 weeks after the beginning, 3 weeks after the beginning, up to the end of the radiotherapy, that usually is 6 weeks after the beginning. So the normal schedule of this radiotherapy is 60 to 70 grays, but is fractionated in the days during all these 6 weeks. So we can follow the patient and address the severity of the mucositis. In fact, if we can go a little bit further, we can have a grade 1 mucositis where the patient have some of course erythema of the mucosa and can feel some soreness of the mouth, but the patient can still eat and drink with a normal diet. Maybe, Susan, we can help this patient. Do you think we can help in some way this patient at the beginning? What do you think?
Yeah, Carlo, thank you. You know, we absolutely can. I think sometimes we are reactive rather than proactive with these head and neck patients, waiting until we start to see something occurring in the mouth. If we get them as dentists and dental hygienists working in conjunction with you, the oncologist, if we get our patients on a regimen immediately from diagnosis, as far as any oral rinses, optimal oral hygiene. All of that, we can work with that patient perhaps to lessen some of these, or just to stay on top of it and wait. Don't wait until it's a grade 3. And then when they're in severe pain, you know, they're reaching out.
Yeah, I think that a very strict hygiene regimen can help, and also the hygiene that the patient can perform by himself can help a lot. So good dental instruction, hygiene instruction can help him.
Yes.
And if we can go further to the next slide, we can see that these ulcers, and also the next image, can be very wide and can affect more the quality of life of this patient. This patient can have problem eating in the grade 2, but they start maybe eating some more easy food, more wet food with a lot of water inside that can help in the swallowing process. Susan, do you agree?
Yes, absolutely.
And so then we can go to grade 3, which is a very severe mucositis, and this patient has to go on a liquid diet, of course, because they cannot of course chew regularly, and they cannot swallow, of course, solid foods. And at the end we go on the 4th grade, which is very severe, and the patient has to go to the has to be hospitalized and go to a parenteral diet, of course. But I agree completely with Susan. We should be proactive, and so maybe we can use some medication about that, which can help us, as we can see in the next slide, I think. Of course, there is another big issue, that is xerostomia, that this patient developed. Susan, what do you think about it? It's a major concern for us.
It is a major concern. And, you know, xerostomia not only comes from the radiotherapy and the chemotherapy, but a lot of these patients already have some degree of xerostomia present. You know, we know most of the population does, from medications, from systemic conditions. So again, just being proactive and getting them on products for dry mouth from the moment of diagnosis to help. You know, the unfortunate thing, Carlo, is we don't have something to totally prevent these conditions. But I think being proactive to help in the progression is key.
Yeah, I have to say that usually this patient, I agree completely with Susan. A major point is that this patient often doesn't suffer only from oral cancer. Maybe they are diabetic, maybe they have hypertension. So they come already with a xerostomia sensation when they come to our department. So the impairment of the salivary glands make it worse and worse. So you can recognize our patient because they come to our department with a bottle of water in their hand. Of course, this is a very sad for us. And in this light, I think that a big help can become from the use of salivary substitutes, which are very important for us because, first of all, they recover the xerostomia sensation, which is, of course, bad and is frustrating for the patient. But the salivary substitute can help us also in the managing of another very poor side effect, which is rampant caries, which we will see later. And I have to say that also the quality of the saliva changes during the radiotherapy, because the saliva becomes more thick, more mucous than the normal one, because the serous cells die before the mucous one. And so, as we can see in this picture, the saliva become very thick. Susan, do you have this experience too? Do you notice that?
Yes, absolutely have this experience with, all of these head and neck cancer patients, and it's a devastating side effect for them, and not just during therapy, but also, as you know, Carlo, long term. Sometimes this can go on indefinitely after treatment.
Yeah, I agree. It's a long term, is never lasting in some cases. So I think that the use of salivary substitute up to now is the most effective therapy that can help these patients. And there are some substitute with the hyaluronic acid, for instance, that stitches to the mouth and help them to have a comfort zone in their mouth, which can help a lot the oral cavity. And but clinically, I would suggest, as we can see in the next slide, to measure the salivary flow, because sometimes patient can have a normal salivary flow, and but they still feel the xerostomia. So it's important to understand if hyposalivation is really present. So usually we collect saliva with this within these tubes, either basal flow and stimulated with citric acid, so we can understand how deep is the hyposalivation, first of all, and match that with the feeling sensation of the xerostomia, that maybe we can investigate more with some questionnaires that help us to understand how is the situation. Do you think that this is a good therapy with the salivary substitute? Do you suggest to the patient, Susan?
Yes, this is something that I'm not as familiar with as you are, Carlo, is testing the saliva. And as you're talking, I'm thinking this could be something, interdisciplinary collaboration with the dentist and the head and neck oncology care to stay on top of what's going on with the patient. I think this is excellent. And
it's very simple, by the way. It's not very, it's very difficult. It's 10 minutes, 5 to 10 minutes time. So it's quite easy to do. And do you have any other suggestions, Susan, for the patient who suffer from xerostomia?
Well, in addition to constantly drinking water, which, and perhaps, Carlo, some of the things that I've read is that perhaps drinking too much water, sipping on water all day, can actually reduce the healthy saliva that's there. I'd like to know your opinion about that. But, nowadays we have so many options of salivary substitutes, but also things that can help stimulate that salivary flow. I do think we need to be careful. Oftentimes it's recommended to patients that they suck on lemon drops or that type of thing to help stimulate salivary flow. But then that's introducing more sugar into the mouth, which then increases the chances of more decay and the rampant decay. So knowing contents of what we're recommending and the side effects of those contents and how they'll have that ultimate effect on the patient, I think is key for us as dentists and dental hygienists.
I agree, Susan. I think that patients should use some sugar-free gums, for instance, because the chewing movement.
Xylitol products.
The xylitol, the chewing movement favor the production of saliva, but of course the risk of it is high. So maybe xylitol gums can be a good point.
Yeah, xylitol products. We know xylitol's an excellent product.
And I usually suggest of using not sparkling beverage, because sparkling can remove the mucus and the saliva from the mouth. So in a certain way, I agree with you that drinking is good, but if they drink too much and maybe if they drink the wrong type of water, sparkling or for instance fruit juice, can be very harmful for their quality of health of the mouth. So I completely agree with you.
Carlo, Susan, sorry to interrupt, but we have a question on xerostomia, so maybe I can just put it on so you can maybe have a look at the first question. We have another one on oral mucositis, but I will reserve that for the end. So the one is on xerostomia is this one. I would like to ask if saliva biomarkers are widely adopted and ordered along with histological testing and other clinical exam in an effort for early diagnosis of oral cancer. What do you think of this question?
Susan, would you answer first?
Sure. I'll address what I know, and from speaking with experts here in the United States, as far as the saliva testing, especially, here we have salivary testing for HPV, presence of an oral HPV. And what that does, what we have here, what that does, it gives a moment in time test of any oral HPV infection. And so what we know is, one day somebody could have an oral HPV infection. The next day, their body could perhaps flush out. The immune system could get rid of that oral HPV infection. So when they come back with perhaps a result of, yes, an oral HPV infection, it's that moment in time. And I think we need to keep that in mind, that we don't know what's happened the next day, the next week, or they could come back with a result of no oral HPV present. And then the next day, the next week, or next month, maybe be exposed and have an oral HPV infection. So as far as, oral HPV salivary tests, they give us that moment in time. They don't give us a long-term view of that infection, which, with some experts,
can I add something, Susan? I think that it can be the future, probably. But nowadays, of course, we have HPV testing, but as Susan said, is just a picture of a wider panorama, I think. So up today, I think that we can use oral cytology, like scraping or rinsing cytology, to follow up just some of potentially malignant disorders. But up to now, the biopsy is the gold standard in the diagnosis of oral cancer. So I
Yes.
think up to now we cannot go without a biopsy. Anyway, I think that in the next future, probably not, in some decades, maybe less, some salivary biomarkers can help a lot.
Yes, wouldn't that
For
be
sure.
nice if we had that available?
Not only oral cancer, but they can help also in the diagnosis of other cancer in the body, probably, but is not yet a reality.
Yeah.
Thank you for your answer to the questions. I hope it answered Hua from our chat box on YouTube. So with the other question I will ask at the end, but we can maybe follow up on the next topic on main conditions in oral in cancer therapies, and come back to your presentation.
Of course, another major problem, Rachel, is oral candidiasis. Of course, these patients have two problems. Of course, they have many problems, but anyway, one problem is that the salivary flow dropped down, so the normal and physiological cleaning of the mouth is completely altered. And also the presence of deep changes in the microbiota of the oral cavity can favor the rise of the candida. So that is a major concern, also because this problem became chronic as the patient goes by, as time goes by. As you can see in the next slide, we usually perform a candida swab to understand if the patient is colonized by candida, because candida lives in many oral cavity of many people, but that's not necessary a pathogens. So the radiotherapy and the salivary flow impairment can cause the rise of the candida. Do you agree, Susan?
Yes, absolutely agree with you. Thank you for covering that.
Is a major problem, this, because we can use some drugs, of course, to treat the candida, but I think the best way is to use some bioactive, some biological help with some probiotics, macrobi, which can help the oral flora to go back to the beginning and do a sort of fight to the candida with a more gentile and not drug-induced therapy. So some probiote can be, and also in this case, I can underline what Susan said, is much better to be proactive, and so make a swab before the starting of the radiotherapy, and follow the patient that he doesn't become colonized by candida, because it can be a major concern.
Yeah, and maybe even, Carlo, start the patients on a probiotic at the beginning of treatment. Before this arises. So it's maybe, again, we can't. There's no absolute to prohibit these conditions from occurring, but perhaps reduce how they do appear for these patients.
I think that we can go farther to another major problem that are rampant caries, as we can see. As we can see in this image, this patient has rampant caries everywhere, and you can see that there is very few saliva in this patient that covers the teeth, and these caries happen on the apical third of the crown, are typical. And Susan, maybe we can play a big role in these patients.
Yeah, we can by staying in contact with the patient, assessing their oral health weekly, which we're going to talk about here in a few minutes. But even now with, silver diamine fluoride, perhaps that is something that we should be looking at further, using at the beginning of treatment to help maybe.
Rachel, if we go further, we can see what Susan, this is a very sad case. We can go further again. We can see the panorex and the clinical presentation of this poor lady. But of course, as Susan said, we can perform some trays to help the fluoridization of the teeth. Susan.
Yeah, from the beginning of diagnosis, have the dentist have that patient in, sit down with them, make the fluoride trays, review the use, and stay in contact with them to make sure that they're using it. Are the fluoride trays, are they having any issues? Are there any adjustments that need to be made?
Yeah, that's true. That's true. And it's very important to prevent the onset of these caries, because once are induced, are very difficult to treat. The enamel and the dentin is very poor, becomes very soft and very easily broken. So maybe we can go to the next slide. And as we can see, many of our patients have a very poor periodontal conditions because, of course, they are smokers. Many of them are smokers, heavy smokers, and maybe they are drink abusers, so alcohol abusers. So the oral, of course, the oral health, periodontal oral health is very poor, as we can see in this image. And Susan, you know a lot about that.
Yeah, hygienists live in periodontal disease, and there's this is a sad case. Where do you begin? Where do you help these patients to keep as many teeth as possible? They already have periodontal
that's
disease,
true. Also,
and then what can we do to help them save as many teeth as possible during this cancer diagnosis?
That is true, Susan. Even because as the patient get radiotherapy, it's a major risk factor, the extraction of a teeth to induce oral osteoradionecrosis of the jaws. So I think that hygienist's role is paramount in treating these patients, because as much as we can take these teeth in the mouth, as much we postpone the possibility to have an extraction, and so to run the risk of develop an osteoradionecrosis. So I think is a very important role that you can play in these patients.
Right, and
scaling.
getting them in before treatment begins to, provide that periodontal therapy for them before treatment begins, to get them as healthy. There's a short time between diagnosis and beginning of treatment. So to get them in to receive this therapy before their treatment does begin, and that, goes into that interdisciplinary care and communication between dentists, hygienists, and the oncology team.
Susan, you point out another concern for us, that this poor patient has to start radiotherapy soon. So we have a very few days to make the general oral health of this patient rise from a poor level to a higher hygiene, higher fluoride intake, help them and start all the procedures that we spoke before about the probiotics and the salivary flow. So we have very few days, because radiotherapy should start 2 months after the major ENT surgery. So actually they leave the hospital 1 month usually after the surgery. So we have just 1 month left to perform all the extraction, all the hygiene protocols, of course. So it's quite demanding.
Right.
Just to bounce on what Susan said about the multidisciplinary work between different specialties and different teams, maybe we can talk about, Susan, about the patient management between all these teams, since we are also to be mindful of the time, to talk about, yes, the patient management that you would recommend for this kind of people, patients with special needs.
Sure.
You? Yes.
Yeah, sure, Rachel. Yeah, if you would like to go on to so a lot of this is going to be a review of what Carlo and I have already talked about. After dentists and hygienists, we've done that thorough head and neck exam, and we've referred our patient for a biopsy with a specialist. It's important that we stay in contact with that specialist to determine, was there a positive cancer diagnosis or not? And then, because oftentimes we're busy and we lose that communication and that connection there. And so if you go on to point number 2, that really brings in then that interdisciplinary approach from the dental team and the patient's oncology team. And Dennis, I encourage you to, once you know there's a positive cancer diagnosis, reach out to the patient's oncology team and let them know your contact information and that you want to be kept abreast of everything that's going on.
That's true.
And be a part of that oral care team for that patient. And let your patient know, hey, we found this, you've been diagnosed, we're still a part of your team. And then immediately get that patient in to review oral hygiene. We know that patients without cancer, they're not always great at following our oral hygiene instructions. And a cancer patient has so much on their plate. They have a lot to deal with. So bring them in, not just for that appointment to get perio taken care of and any restorative work or extractions, but have a separate personal appointment with them to review oral hygiene instruction, brushing, and it probably isn't going to be flossing, using interdental brushes. You know, Gum, Sunstar has a great post-op soft toothbrush that they should be using during care. It's a manual toothbrush, a powered toothbrush isn't always going to be the optimal toothbrush for an oral cancer patient. And so using that soft toothbrush and changing that toothbrush on a regular basis and keeping it clean while they're using it, I think could be key to maybe helping reduce some of these oral side effects, because we know often patients will have their toothbrushes sitting on their bathroom counter and they just don't stay clean. So reviewing with them, again, proper brushing technique, keeping that brush clean, changing that brush perhaps on a weekly basis, looking at the array that we have a myriad of products out there to help with just what we've talked about, xerostomia and all of that. So having a regimen of products for them to choose from, because often we know that maybe one product will work for them for a while, but they may need to change products if something stops working for them. And stay in contact with them. Have weekly visits with them. Have them come in. Or even better yet, wouldn't it be optimal if we could have a hygienist in cancer facilities where treatment is being given on a daily basis to look at patients intraorally and see what's going on? Do they have a stage 1 or stage 2 diagnosis going on as far as xerostomia or I'm drawing a blank here. My mind's
yes, for instance, mucositis.
Yes, mucositis.
I agree that dental hygienists should be a part of a cancer team. Of course, head and neck cancer, but also in the regular tumor boards of other part of the body, because
Yes.
it's part of, they and we can help the quality of life of these patients.
Yes,
with
absolutely.
our help and with our love to these patients, and I think that is very important.
Yeah, absolutely. You know, and in fact, here in the United States, we have it's called National Network of Healthcare Hygienists, and we're creating a program to educate hygienists to go into cancer facilities and be that main contact, because a patient may not always be able to get into their dental office. And so having an educated oncology hygienist present can really help these patients.
Yeah.
Great.
I would like to say just the last thing, Rachel, if we have time, because I see the time goes by, but I would like to thank Sunstar for allowing us to share our daily clinic, because the images that you see in this presentation are our daily patients. So are very, very, very sad patients and are very demanding, and we need the help of a multidisciplinary task to treat them, because are very complicated, very delicate, and so I would like to thank you that allow us to show our reality to other people, other colleagues.
Actually,
thank you very much.
Actually, we, Sunstar, on behalf of Sunstar, would like to thank you both for actually bringing in your clinical expertise, because of course that is the point of Sunstar, to share the knowledge of people who are working with people with special needs, special conditions, and it's important to adapt the care and of course education to bring the best to the patients. And as you just rightfully said, the best work is actually the teamwork, and the work between the different specialties will always benefit the patients in the end. And I think with the overview of the main oral main cancer therapies and the oral conditions that come up with them, you gave today a very good overview of all that. So thank you very much to both of you.
Yeah,
thank you, Susan.
Thank you, Carlo. Susan. Thank you, Carlo. Thank you, Rachel. Thank you, Sunstar, for highlighting this.
But actually I will still pick your brain a little bit more, if you allow me, because we have several questions from the audience, and they are actually I would like to bring the answer to them. So let me just check the first question to make it so the person on YouTube said that they see that most of oncologists are not aware of oral mucositis. Clinicians say frequently that there are not many patients with expressed mucositis, not more than 5%, even in oncohematology. So the question is from our auditor is why is it that way? Why clinicians are not aware, and how to make them aware? Maybe we need to involve nurses to the validation. So just before I let, of course, you answer, this is exactly what we said, teamwork with different specialties. But what would you like to answer?
Rachel, I completely agree with this colleague, because the point is that probably when we speak about a multidisciplinary approach, we speak about not only dental team, but of course nurses can be involved in this path. Susan, what do you think about? I think it's a good idea.
Oh, absolutely, it's a great idea. You know, there's not a plate here separating the head and neck from the rest of the body. It's, you know, this oral systemic condition, and the more everybody knows about the oral cavity and these conditions that can arise, just the better care these patients will receive.
Great, thank you for your answer. Another question. It would be great also to know about the speaker's experience in administration of Gel-X oral spray and its effectiveness comparison with any other anti-mucositis solutions. I think, Carlo, you have experience with that.
Yeah, we have a very good experience because our the protocols used by our radiotherapy, we didn't have time to speak about many topics. You know, I think we just gave a glance of the contour of this of these patients. But anyway, we have a wonderful experience with Gel-X in the treatment of mucositis. And you know, it's much. We are performing also some study because our radiotherapies gives a bicarbonate solutions, which is thought to be the gold standard. But I think that Gel-X is much better, and they have, as Susan said, in this case we must be proactive. So start the administration before the onset of the mucositis. Otherwise, once it's on, once it's switched on, the mucositis is very difficult to switch it off.
Thank you, Carlo. Susan, do you want to add something else or not on this specific question?
I think Carlo covered that perfectly.
Okay, and then the last question, because we are already over time, but still I'm really keen to answer to Vadim about please advise on which kind of patients oncologists need to pay more attention regarding the risk of oral mucositis development. Which parameters of patients need to consider first?
Okay, I think in our experience, of course, late stages of ENT cancer are the most prone to develop oral mucositis because they receive high radiotherapy doses together with maybe an adjuvant chemotherapy. So they combine two side effects of the two therapies. And we are producing some data about that. In this sense, we noticed that the presence of Candida at the beginning of the radio and chemotherapy is a risk factor, not only for the onset of the oral mucositis, but also for the grade of the mucositis and the timing. Usually these patients develop an early mucositis. So I suggest that this patient and also patients who undergo some chemotherapy like Marfalan for oncohematologic problem are very prone to develop oral mucositis. So these two patients, in my opinion, are the worst patients.
Thank you, Carlo, for your answer. I hope we answered to Vadim's questions. We are already a bit over time, so to be considerate of the time of everybody, I would just like to conclude this session by thanking you both for your time again and for your expertise that you were willing to share with our audience, different perspectives for different, for a teamwork that works best for the patients. So just for also our audience, since we have a lot of questions on oral mucositis, just for you to know that if you want more information, yes, Carlo?
If Sunstar invite us again, we can do another webinar
yeah, I know. We know that you have extensive knowledge on cancer therapies and oral cancer, so we will be delighted to have you again, of course. But in the meantime, if for the audience who is interested by oral mucositis, please just note that you, Carlo, with Dr. Scambia and Sunstar developed a clinical guidebook on oral mucositis that you can find on sunstar.com and by the link that you can see here on the screen. So I will not keep anyone any longer, but again, thank you for this extremely interesting exchange on oral mucositis, which is not a very common topic, but still really is worth mentioning, mucositis by oral cancer in general. So I hope the audience took some information and insight in case they encounter such patients. And also, we hope to see you on July 5th for the next webinar, which will be on home-based oral care for special needs patients. So stay updated by subscribing to YouTube channel and Sunstar social media channel as well. And thank you again for your company to everyone for today. And we hope to see you soon.
Thank you, Rachel. Thank you so much.
Thank you, Susan. Thank you, Carlo. Thank you to our audience. Bye-bye.